The theories and models we discussed in the last video were generic. As with most descriptions of leadership, they're primarily aimed at people who have been appointed to roles of leadership. Most contemporary research on the subject addresses the behaviour of appointed leaders in areas such as firefighting, policing, and the military. In healthcare, such appointed leaders are not so apparent. Organisations like the fire services, the police and the military use a single pyramid-like command structure. At each level of the pyramid, there is a leader who is in charge of usually between 2 and 10 individuals. This structure is often reinforced by visible symbols. The Royal Navy, for example, has ranks for Commodore, Captain, Commander and Lieutenant. The uniform of each rank has clearly identified markings. Healthcare is different, with not one, but multiple command pyramids, such as the medical staff, the nursing staff, and the administrative staff. Therefore, in an operational unit such as a surgical team, different members are answerable to different command lines rather than to a single team leader. Nurses are answerable to the nursing hierarchy, administrative staff to their own hierarchy, and medical staff to senior doctors. This often leads to conflicting expectations. How does a senior nurse deal with a junior doctor who is not in his command line but wishes to do something contrary to instructions from above? The multiplicity of command lines leads to the many challenges that healthcare workers are familiar with. The administrative and nursing command structures are similar to other organisations with fairly clearly defined ranking. In the case of nursing staff, they also have identifying attire, but the whole organisational structure has another character courtesy of the medical profession. The medical command structure in the UK NHS consists of medical directors over clinical directors of directorates and heads of clinical departments. Then there are consultants, specialist trainees and foundation trainees under them. The rankings above consultant do not apply to the operational front line. Traditionally, the operational structure was of teams or firms headed by consultants, under which there were senior registrars, senior house officers and house officers. As with other organisations, there were more juniors than seniors. Things are changing in the NHS with a greater increase in number of consultants than in the number of juniors, meaning that the number of consultants and juniors are more similar, and they are not organised into firms as they once were. The result is a flat command structure with large numbers of consultants who are independent practitioners of equivalent seniority, and junior doctors who have numerous masters, each with their inevitable idiosyncratic differences. This is what Henry Mintzberg describes as a professional bureaucracy. The dominant role of the medical profession in healthcare makes the overall command structure a professional bureaucracy. According to Mintzberg, they have predictable properties. Stability is prioritised over change. Work is organised in many multidisciplinary teams. The function of leadership is distributed to many professionals. Leadership skills training is important for many professional groups. Frontline staff have control over work content and more influence than appointed managers on day-to-day decisions. Leaders have to negotiate changes rather than impose them. Hierarchical directives have little effect. High rank is not always followed or respected. Influence is more significant in achieving change. Professional networks and peer pressure are very important. Professional credibility is important. The result is that large numbers of NHS employees need particularly democratic leadership skills.